Okay, now let's switch gears and start our discussion of the lymphatic system. So it's going to be chapter 21, and then we'll follow chapter 21 with a discussion of the immune system in chapter 22. Both of these systems are very closely related. Okay, so what does the lymphatic system do? Well, it's going to transport and house lymphocytes and other immune cells. And it's going to return the excess fluid in body tissues that we talked about in our cardiovascular discussion. It's going to take that excess fluid and return it to blood in order to maintain blood volume. The lymphatic system components include the lymphatic vessels, lymphoid tissues and organs, and lymph, which is the fluid that's transported within those lymphatic vessels. Okay, so remember, some fluid is going to leave those blood capillaries and not be reabsorbed by them, and it becomes the interstitial fluid. That interstitial fluid then moves into the lymphatic capillaries, where it is then called lymph. And the components of lymph are going to be water, dissolved solutes, and a small amount of proteins. And then it's also going to include immune cells, and may also contain cellular debris, microorganisms such as pathogens, microbes that can cause disease, and cancer cells. Okay, what are the lymphatic capillaries? Well, these are small, closed-ended vessels that are absorbing the interstitial fluid. They're going to be interspersed around most of the body's capillaries. They're going to be absent in avascular tissues such as epithelial tissue and cartilage. They're also absent in the red bone marrow. They're present around the brain in the meninges. These guys are larger than blood capillaries, and they lack a basement membrane. The walls of lymphatic capillaries are going to be made of overlapping endothelial cells, which I'll show you in a second. But this overlapping creates flaps between the cells, which allows fluid to enter the capillary, but then the fluid cannot exit. So they kind of work like almost like a valve. There are these anchoring filaments that hold the endothelial cells to nearby structures. Lacteals are specifically the lymphatic capillaries in the GI tract, and these guys absorb lipid-soluble substances from the GI tract. Okay, so here you can see an arteriole feeding a capillary bed, and here you can see these closed-ended lymphatic capillaries that are kind of intimately intertwined throughout these capillaries and allow that interstitial fluid to be drawn into them. If you look closely at an individual lymphatic capillary, you can see the endothelial cells here and how they overlap and how this allows for the one-way flow of fluid into the vessel. You can also note the anchoring filaments here anchoring those epithelial cells to nearby structures. Okay, how does lymph move into those lymphatic capillaries? Well, it's going to be the hydrostatic pressure of the interstitial fluid that's going to push it into the lymphatic capillary. Those anchoring filaments hold those endothelial cells to surrounding structures, preventing the vessel from collapsing. And the pressure of the lymph inside the vessel is going to force those intercellular openings, those flaps, closed, keeping the fluid inside of the lymphatic capillary. Now, lymph is going to move through vessels of larger and larger size. It's going to go from lymphatic capillaries to lymphatic vessels to lymphatic trunks and finally lymphatic ducts. Ultimately, those ducts are going to return lymphatic fluid to the blood circulation. Okay, what role does the lymphatic system play in metastasis? And what exactly is metastasis? Well, wandering cancerous cells can establish secondary tumors distant to the primary tumor, that is the original site of the cancer. And when these cancerous cells develop in other locations in the body, this is called metastasis. For example, breast cancer, a cancer that occurs initially in the breast, can metastasize or move to the lung. What happens is cancerous cells are going to break free from that primary tumor, and they're going to be transported in the lymph. And from there, they can reach the circulatory system and can be seeded throughout the body. Okay, so we have the lymphatic capillaries, and they're going to feed into lymphatic vessels. Lymphatic vessels are located adjacent to arteries and veins. They have all three vessel tunics, that is the intima, the media, and the externa. They have valves that prevent pooling and backflow of the lymph. Okay, so they look a lot like veins at this level. The lymphatic system lacks a pump, so it moves lymph using skeletal muscles and respiratory pumps like what you see in the veins. It also moves lymph using the pulsatile movement of blood in the nearby arteries, as well as rhythmic contraction of smooth muscle in the larger lymph vessel walls. Some of these vessels are going to connect to lymph nodes for filtration. Okay, so lymph nodes filter the lymph. Those lymphatic vessels are going to feed into lymphatic trunks, and you have several lymphatic trunks throughout your body. You have the jugular trunks. These are going to drain lymph from the head and neck. The subclavian trunks, which drain the upper limbs, the breasts, and the superficial thoracic wall. The bronchomediastinal trunks. These guys drain the deep thoracic structures. Intestinal trunks drain most of the abdominal structures. And lumbar trunks are going to drain the lower limbs, the abdominal pelvic wall, and the pelvic organs. Finally, the lymphatic trunks are going to drain into lymphatic ducts. These are the largest lymphatic vessels, and these are the guys that are going to bring the lymph back to the rest of the circulation. There are two lymphatic ducts, the right lymphatic duct and the thoracic duct. The right lymphatic duct is near the right clavicle. It's going to drain the upper right quadrant of the body, so the right side of the head and neck, the right upper limb, and the right side of the thorax. It's going to deliver lymph to the junction of the right subclavian and right internal jugular veins. Then you have the thoracic duct. This is the largest lymphatic vessel. It's going to run from the diaphragm to the junction of the left subclavian and left jugular veins. It has a sac-like cisterna chyli at its base, and what this does is it receives lipid-rich chyle from the GI tract. It's going to drain lymph from the left side of the head and neck, the left upper limb, the left side of the thorax, the entire abdomen, and both lower limbs. All right, so here at the bottom right, you can see the lymph drainage pattern. So you can see the area drained by the right lymphatic duct here is going to be the right upper limb, the right breast and right thorax, and the right half of the head and neck. The rest of the body is going to be drained by the thoracic duct. Up here you can see the right lymphatic duct. You can see it's draining into the junction of the right subclavian vein and the right internal jugular vein. You can see that it's fed by several different trunks. Down here is the cisterna chyli at the bottom of the thoracic duct. You can see it is fed by several trunks. And then you can see the thoracic duct climbing superiorly here until it reaches the junction of the left subclavian vein and the left jugular vein. Okay, what is lymphedema? This is going to be interstitial fluid accumulation due to some kind of interference with lymphatic drainage, and it's going to cause swelling and pain in the affected area. Lymphedema can interfere with wound healing, and it can contribute to infection of the affected area. Most lymphedema is going to be caused by a blockage of a lymphatic vessel. Examples that can cause damage or blockage to lymphatic vessel: trauma, parasitic infection, tumors, scarring from radiation therapy, and removal of lymph nodes. You control lymphedema with compression garments, exercise, and massage. Extreme cases are going to be known as elephantiasis, and these are caused by infection with parasitic worms. Here are examples of elephantiasis. So you can see the affected limbs have massive swelling in them, and this is due to the lymphatic vessels being blocked by parasitic worms. All right, now let's talk a little bit about lymphoid structures. So you have primary lymphoid structures and secondary lymphoid structures. Primary lymphoid structures are going to be involved in the formation and maturation of lymphocytes. And your primary lymphoid structures are going to be the red bone marrow and the thymus. Then you have secondary lymphoid structures. These guys do not form lymphocytes, but instead they house them as well as other immune cells. And they're going to provide the site for the initiation of the immune response. Secondary lymphoid structures include lymph nodes, the spleen, and lymphoid nodules. These are clusters of lymphoid tissue in various organs. And they're going to include MALT. This is the mucosa-associated lymphoid tissue. And this is going to be things like tonsils and GALT, or gut-associated lymphoid tissue, such as the Peyer's patches. Let's start with the primary lymphoid structures. Red bone marrow. Remember, this is going to be located between the trabeculae of spongy bone within the bone itself. And you'll find it in the flat bones of the skull, in the ribs, in the sternum, the vertebrae, the ossa cocci, or the hip bones, and the heads of the humerus and the femur. Red bone marrow is going to be the site of hematopoiesis. Remember, this is the production of the formed elements of blood. Formed elements are going to include those T cells and B cells, the T lymphocytes and the B lymphocytes. Now, immature T lymphocytes, which are called thymocytes, are going to be born in the bone marrow, but they're going to migrate to the thymus to complete their maturation. Okay, so this is showing the different formed elements of hematopoiesis. So these are all the elements and cells that red bone marrow makes. And you'll see we've got red blood cells, we've got platelets, we've got our granulocytes, we've got monocytes, we've got B cells, and then immature T cells, which are called thymocytes. And the thymocytes cannot mature in the red bone marrow. They have to leave and go to the thymus, where they finish maturing and eventually return to circulation as T cells or T lymphocytes. That brings us to the second primary lymphoid structure, the thymus. The thymus is involved in T lymphocyte maturation. It's going to be located in the mediastinum, right anterior, right on top of the heart. It's larger in children than in adults. So it's going to grow in children until about puberty. Then it's going to regress, and as we age, it's gradually replaced by adipose tissue. It's going to consist of 2 thymic lobes, and each is going to be surrounded by a connective tissue capsule. Now that capsule has these things called trabeculae, which kind of dive into the thymus and subdivide those lobes into lobules. Each lobule is going to have an outer cortex and an inner medulla. Both regions, the cortex and the medulla, are lymphoepithelial. That means that they have lymphatic cells and epithelial tissue. The cortex is going to contain immature T lymphocytes, while the medulla contains the mature T lymphocytes. Okay, so we're looking at the thymus under the microscope here. So on the left is a micrograph of a child's thymus. On the right is an adult's thymus. And right away you can see there's just not much functional tissue left in the adult's thymus compared to the child's thymus. Now looking here, you can see the capsule, and you can see how it has this trabecula that kind of dives into the thymus and kind of creates a little lobule here. Now in this lobule there's the cortex, and this contains immature T cells. And then as those T cells go through their maturation process, they're going to migrate to the medulla. And the medulla is where the mature T lymphocytes are going to be. Okay, now let's talk about the secondary lymphoid structures. These guys house lymphocytes as well as other immune cells within a reticular connective tissue matrix. They're going to be organized into lymphoid organs and aggregates of lymphoid nodules. Organs are going to have a complete capsule of dense irregular connective tissue around them. The examples here are going to be the spleen and the lymph nodes. Other lymphoid structures have an incomplete capsule or completely lack one. And so they're better described as aggregates of lymphoid nodules. So this would be things like the tonsils, the mucosa-associated lymphatic tissue, and diffuse lymphoid nodules that you can find throughout various organs. All right, lymph nodes. These guys filter lymph, okay, and they remove unwanted substances from that lymph. They're small, oval, and encapsulated, and they're going to be located along the deep and the superficial pathways of lymph vessels. They occur in clusters receiving lymph from different body regions. So you'll find clusters of cervical lymph nodes that receive lymph from the head and neck. Okay, so those are going to be in your neck. You'll find axillary lymph nodes. These guys receive lymph from the breast, the axilla or the armpit, and the upper limb. And then there are inguinal lymph nodes down in the groin that receive lymph from the lower limb and the pelvis. Components of a lymph node. So you're going to have afferent lymphatic vessels. These guys bring the lymph to the node. Then you're going to have a single efferent vessel that drains the lymph node. And this guy's going to be located at the hilum. I'll show you that in a second. It's going to have a dense connective tissue capsule enclosing it. And again, you're going to see trabeculae of that capsule subdivide the node into compartments, just like what we saw with the thymus. There's an outer cortex and an inner medulla. All right, so here are those afferent vessels bringing lymph into the node. And you can see here's the hilum, and here's the efferent vessel taking lymph out of the node. Here is the cortex of the lymph node. We'll talk about this in a second. And here is the medulla, the inner part of the lymph node. The cortex is going to contain lymphoid nodules. Lymphoid nodules are reticular fibers that support a germinal center. The germinal center houses proliferating B cells, as well as some macrophages. And the germinal center is going to be surrounded by a mantle zone that contains T cells, macrophages, as well as dendritic cells. The cortical sinuses are tiny open channels that are going to be lined by macrophages. So here's the cortex. Let's zoom in, and you can see the germinal center here. You can see the surrounding mantle zone, and then you can see the cortical sinus. The medulla of the lymph node is going to contain medullary cords. These are connective tissue fibers that support B cells, T cells, and macrophages. And then you'll find medullary sinuses, which are tiny open channels lined with macrophages. Okay, so if we zoomed into the medulla, this is what we would see, and we would see a medullary cord surrounded by medullary sinuses. All right, how does lymph flow through the nodes? Well, remember, it's going to enter through those several afferent vessels, and these multiple afferent vessels are going to create pressure that pushes the lymph through the node to that single exit vessel, the efferent vessel. During this, lymph is going to be monitored for the presence of foreign material. Macrophages are going to remove foreign debris from the lymph. Lymphocytes may initiate immune responses. Lymphocytes are going to proliferate in the germinal centers, and this can cause enlarged lymph nodes that can be palpated, especially in the neck and the axilla. This is one of the reasons why lymph nodes can enlarge during infection, is because those lymphocytes in the lymph nodes and the germinal centers are proliferating. Lymph is going to exit the node through that single efferent vessel, and then it can pass on to neighboring lymph nodes. All right, let's talk a little bit about lymphoma. What is lymphoma? Well, this is going to be a malignant neoplasm, right, a cancer of the lymphocytes, and it's going to involve lymphoid structures. Signs of lymphoma include non-tender enlarged lymph nodes, and some patients can get night sweats, fever, and weight loss too. And this is due to the cytokines being released from those malignant immune cells. There's two general types of lymphoma. There's Hodgkin's lymphoma and non-Hodgkin's lymphoma. Hodgkin's lymphoma tends to affect young adults and people over 60. If caught early, Hodgkin lymphoma is highly treatable. It can be cured by excision, radiation, and chemotherapy. Non-Hodgkin lymphoma is the more common form, and the aggressiveness is going to vary. Some kinds of non-Hodgkin's lymphoma are aggressive, other kinds are slow growing, and really it just depends on which immune cell is involved and what the mutation is in that cell that's causing the cancer. Okay, let's talk a little bit about palpating lymph nodes for diagnosis. So we said lymph nodes house the T cells and the B cells. Nodes can normally be palpated in the head and neck. Okay, so if you use your fingers and you feel along your sternocleidomastoid muscle, you feel just anterior to that, up and down your neck, you may feel these tiny kind of flat, rubbery feeling beads. Okay, and those are lymph nodes, and they're normal to feel around the head and neck. In other areas, though, such as your axilla and your inguinal region, you really can only feel lymph nodes when they become enlarged. Enlargement of a node can occur in response to infection. What palpation does is it evaluates the size of the lymph nodes as well as other characteristics such as, are these tender? Does the patient wince when I palpate these lymph nodes? It can point to different diagnoses. For example, in mononucleosis, the patient tends to have a very sore throat, a fever, and a swelling of all the nodes throughout the body, but especially the posterior cervical chain. In a cold, swelling of the lymph nodes is going to be limited to the cervical nodes, right? The nodes that drain the head and neck, because the cold tends to affect just the head. More common with cancer, you will see enlarged, hard to the touch, non-tender nodes. With infections, the nodes are enlarged, but they tend to feel fluctuant or a little bit rubbery, sometimes even a little cyst-like, and they tend to be tender. Okay, so this is a look at the lymph nodes, the head and neck. So for example, here's your preauricular lymph nodes. Here's the submandibular lymph nodes, the submental lymph nodes. I want to draw your attention to the anterior cervical lymph nodes and the posterior cervical lymph nodes. And here in between is the sternocleidomastoid muscle. So anterior to the SCM, you can feel the anterior cervical chain. And posterior to the SCM, you'll feel the posterior cervical chain. There are also supraclavicular lymph nodes. That brings me to Virchow's node, or Toisier's sign. What this is an enlarged left supraclavicular lymph node. This is going to be located just above the clavicle, near the junction of the thoracic duct and the left subclavian vein. Why is this clinically significant? Well, Virchow's node is often a sign of abdominal or thoracic cancer, especially gastric cancer, pancreatic cancer, lung cancer, and lymphoma. Why is it on the left side? Well, remember, the thoracic duct is there, and the thoracic duct drains lymph from most of the body into the left subclavian vein. Cancer cells traveling via the lymph may lodge in that left supraclavicular node, and that can lead to its enlargement. And here is an example of Toisier's sign or Virchow's node. Okay, next in the secondary lymphoid organs, we have the spleen. This is the largest lymphoid organ. It's going to be located in the left upper abdominal quadrant. It's going to be lateral to the left kidney and posterolateral to the stomach. Posterolateral aspect of the spleen is convex and rounded, and the anteromedial border is going to be concave. It kind of looks like a big lymph node. It has a hilum. This is the indentation where blood vessels and nerves enter the spleen. The splenic artery supplies blood while the splenic vein drains it. The spleen is going to be surrounded by a connective tissue capsule. And again, you'll see trabeculae from that capsule extend into the spleen, and it's going to divide the spleen into red and white pulp. Here's showing you where the spleen is in the abdominal cavity. So this is the left upper quadrant here. They've removed the stomach and the part of the small intestine here so that you can really visualize the spleen and the vessels going to and from the spleen. Here is a look at the medial surface of the spleen, and you can see the hilum here where the vessels and the nerves enter and exit. Okay, the spleen is going to be made up of this stuff called white pulp and red pulp. White pulp is just clusters of T cells, B cells, and macrophages around a central artery. Red pulp is going to contain a bunch of different things: red blood cells, platelets, macrophages, and B cells. Red pulp also has splenic cords. These are cells in reticular connective tissue surrounded by splenic sinusoids, which are very permeable capillaries. Red pulp is going to be the storage site for erythrocytes, or red blood cells, and platelets. Okay, so here we're looking at the histology of the spleen. So you can see these clusters of kind of purple and light pink cells. This is going to be the white pulp. It has a central artery. This region here is the red pulp, okay? Here's the capsule, and here's the trabecula coming from the capsule that's kind of subdividing the spleen. Now, if you were to look at what individual components look like in that white pulp, you would see here's the central artery, blood flowing through it, and then you can see the red pulp surrounding the white pulp, and the red pulp is going to be made up of splenic cords and splenic sinusoids. Okay, how does blood flow through the spleen? Well, it's going to go from the splenic artery to the central artery of that white pulp, through the sinusoids of the red pulp, and then it's going to collect in venules and ultimately form the splenic vein. Remember, the spleen is going to filter and monitor blood, not lymph. It's very much like a lymph node, but it's filtering blood. White pulp cells are going to monitor the spleen for foreign materials and bacteria, and they're going to initiate immune responses when they detect microorganisms in the blood. Macrophages in those sinusoids of the red pulp are also going to remove particles. They phagocytose bacteria and debris, but also they break down those defective red blood cells and platelets. This is going to be a blood reservoir and storage site for red blood cells and platelets. What else does the spleen do? Well, it can make blood cells. In fact, in the first 5 months of fetal life, that's pretty much all it does. Now, in adulthood, it doesn't have that function anymore, but that function can be reactivated under certain conditions. For example, some hematologic disorders, such as genetic anemias like beta thalassemia or sickle cell disease, or myelofibrosis. This is where the red bone marrow gets gradually replaced with fibrotic tissue, scarring. Now, when the spleen does make blood cells, that's called extramedullary hematopoiesis. Okay, splenectomy. What is it? This is going to be the surgical removal of the spleen. It can be performed for a variety of reasons. Most commonly, it's done because the spleen has ruptured from some sort of injury. However, infection, cysts, or tumors are reasons to remove the spleen. So is lymphoma or any other kind of cancer. And some blood disorders, for example, a splenectomy may be required in sickle cell anemia. Those who have had a splenectomy may be more prone to life-threatening infection, remember, because the spleen does filter and monitor the blood for microorganisms. All right, let's talk a little bit about tonsils. Tonsils are secondary lymphoid structures. They're involved in immune surveillance of inhaled and ingested substances. They have tonsillar crypts. These are invaginations in the tonsils that trap material. And they contain lymphoid nodules, some of which have germinal centers. And you can see we have pharyngeal tonsils, we have palatine tonsils, and we have lingual tonsils. The pharyngeal tonsils are located in the nasopharynx, and these are the ones that we call adenoids, okay, especially when they're enlarged. The palatine tonsils are in the posterolateral oral cavity, and these are the guys that you can see when you open your mouth and look back at the back of your throat. Then you have lingual tonsils. These are going to be along the posterior 1/3 of the tongue. Okay, that brings us to tonsillitis and tonsillectomy. So what is acute tonsillitis? This is going to be inflammation and infection of the tonsils. Most commonly affected are going to be the palatine tonsils. What you see is they get red, they enlarge, sometimes they have pus on them or exudate, and they may partially obstruct the pharynx. Fever, chills, sore throat, and difficulty swallowing are all symptoms of acute tonsillitis. Infection can be caused by viruses or bacteria, and persistent recurrent infections or chronic tonsillitis may require surgical removal of the tonsils or tonsillectomy. All right, and this is just showing an image in the back of the throat of a patient who has acute tonsillitis. You can see the redness of the tonsils, the palatine tonsils here, and very swollen. They should not be this close to the uvula. You can also see patches of exudate throughout the tonsils. Okay, lymphoid nodules. These are clusters of lymphoid cells that have some extracellular matrix. They're not going to be completely surrounded by a connective tissue capsule. They have a pale center called the germinal center, and this is going to be the site of proliferating B lymphocytes and some macrophages. In some areas, lymphoid nodules are going to group together to form larger structures. For example, aggregations within the mucous membranes are called MALT, or mucosa-associated lymphoid tissue. An example of that would be the Peyer's patches in the intestines. Okay, so MALT is going to be located in the GI tract, the respiratory tract, the genital tract, and the urinary tract. It's going to be found in the lamina propria. This is that thin layer of connective tissue that lies beneath the epithelium and mucous membranes. So this lymphoid tissue is intimately associated with the lining of the mucous membrane. So it's right there for any pathogens that might cross that mucous membrane. MALT helps defend against foreign substances, and it's going to be prominent in the small intestines, especially the ileum. Here it's called Peyer's patches, or gut-associated lymphoid tissue, GALT. These are large aggregations of lymphoid nodules within the wall of the GI tract.